Yep. Yeah.
Okay. Good morning. Welcome to Sanjeevani Ashramam's Health and Wellness Series number 15. Today we'll be talking about headaches. Dr. Shaila Pinedi will be taking us through the presentation today. In 2 weeks, we'll be talking about Parkinson's disease. Thank you.
Thank you, Rajagara. Good morning to everyone. I guess it's morning in the US, but in India it's evening. So I'm going to talk about headaches, but I'm going to go through the slides. Can you give me the next? So we have this health and wellness series as part of VT Seva, which is volunteering together for Seva, started by His Holiness Chinnajira Swamiji. This started as Vikas Tarangini in India more than 30 years ago, but in US it is 17 years old, and we've been doing various activities, not only in US but also abroad, other countries as well. So the activities are several activities, including serving the needs of disadvantaged communities, helping people during natural disasters and calamities, also developing and grooming young kids to be potential future youth leaders. Can I have the next slide? So VT Seva is in New Jersey in Sanjeevani Ashram in Willingboro, and here our focus is on health and wellness. We have presentations every other week. It's usually on physical or mental health, and today's presentation is number 15. We have also been donating healthy snacks, fresh fruit and nuts, to underprivileged individuals, particularly with serious mental illness without any resources. So we have had now 29 weeks of weekly donation, and it's always on Tuesday, falls on Lord Hanuman's Day. More than 1,200 individuals have received these healthy snacks and are very appreciative as well. So how do you get involved in VT Seva? So there are 3 ways. One is to get involved as an adult or a youth. You can volunteer your time in person or even remotely. You can also help in obtaining some of the resources, fundraising, donations. So, and also spreading the word to more people to be included in this part of the Seva. So one way to donate is, donation is not big. It's as little as $21 a week. You just have to go to their website there, choose the amount you want to donate, and choose the fund, and this writes Sanjeevani. And then step 4 is fruit and nut healthy snack donation. With that, I'll get started. So as I said, I'm going to talk about headaches. So headaches actually encompass a vast spectrum. Some of these headaches are benign, like migraine headaches or tension headaches, but they can also be malignant, such as brain tumors. And then the extreme one would be life-threatening if you have a brain bleed. So therefore, it is very important to discern a benign headache from something that is very life-threatening or something very serious. For example, meningitis. It can easily be treated in a timely fashion if diagnosed accurately and at the appropriate time. But if you leave it undiagnosed and untreated, it can be life-threatening as well, particularly TB meningitis in the developing countries like India. And the other one is a life-threatening situation, is a ruptured aneurysm. That too needs seek medical attention in a timely fashion. So the rest of the headaches, pretty much I'm going to talk about it, is migraines, tension headaches, cluster headaches, brain bleeds obviously, and trigeminal neuralgia, and then aneurysm of course, and then headaches that are associated with brain tumor. And then there's something called pseudotonal cerebri and meningitis. So the treatment for all these conditions varies from simple medications to something, emergent intervention. Next slide, please. So migraine, I will talk to you because that's the most common headache that we see, and it's also the most ubiquitous neurological condition. Again, like I said, it's important to discern a normal headache that is benign from something that is life-threatening. So the most common headache, as I said, is migraine headache, and the prevalence is about 12 to 15%. It's much more prevalent in women than men, and you can see that it's 1 in 5 women, so 20% of them have experienced at some time or the other. In men, it's only 1 in 16, but pre-puberty, it's equal in boys and girls. It is the second leading cause of disability. Headaches can be very debilitating. There's a loss of work productivity, and also impedes daily activities as well. The migraine headaches are bimodal distribution. The first peak is usually in the teens, like when the menarche, which is basically when the menstrual cycle starts, and the second one is actually perimenopausal in the 50s. Excellent. So migraine, where does it occur? So it can be one-sided, it can be both sides. It's usually preceded by some warning symptoms. Those are called as auras, and the auras can be varied. They can be as simple as seeing some, light visual obscurations, like seeing, black spots, or sometimes flashy light, zigzag lines, or sometimes even scintillating spots. In a severe case, you can see numbness and tingling on one side. You can see even weakness. Sometimes it's a speech arrest. Usually these proceed and then the headache follows, but sometimes you can have even during the headache, so concomitant with the headache, or sometimes even without a headache. All you have is an aura and the headache doesn't follow. It is a recurrent disorder. It occurs, several times a month or once or twice a week, and it can be episodic, occurring, less than 15 days a month. People who suffer a lot, the chronic conditions where chronic migraine, where it occurs about 15 days per month. So it is hereditary. If you get a family history, you'll say the mother has, or siblings have, or mother's siblings have. So usually it is hereditary, but there is no clear-cut one gene. It's polygenic. I mean, multiple genes are involved. And then sometimes when you have a trauma, like a motor vehicle accident or even a concussion, that can actually precipitate the headaches. If you have a history of headaches prior to that, then they actually exacerbate. So they can increase in frequency and intensity as well. In addition to the auras, there's something called as a premonitory phase. This usually is more common than it's actually repeated because people don't recognize that. Or what happens is you get the premonitory symptoms like even 1 day, 2 days prior to the onset of headache. And what are the premonitory symptoms? Usually it's fatigue, it's irritability, it's constant yawning for no apparent reason. You would have slept well, but you still have yawning, neck pain, and sometimes even difficulty focusing and concentrating. The postdrome, similarly, the postdrome following the headache, you feel very tired, you do have concentration difficulty, and also neck stiffness. Next slide, please. So the mechanism of the migraine is, usually there's dilatation of these blood vessels. But that alone cannot account for that. There are other mechanisms, and recently, not recently, but a few years ago, we discovered that there are these inflammatory peptides. There's something called CGRP, which is calcium gene-related peptide, and substance P. In fact, the pharmaceutical industry actually have utilized that CGRP and came up with these antibodies to that to prevent headaches, which we'll talk about in the treatment. And there's also neurotransmitter serotonin, which is involved, and this can really account for other comorbid conditions such as anxiety and depression as well. So complicated migraines is when they manifest with numbness, tingling, one-sided weakness, speech arrest. Then it goes into the realm of complicated migraines, and these can mimic because you cannot discern when the patient immediately presents to the emergency department. You really can't differentiate whether it's a stroke or a migraine, so it warrants a workup with an MRI of the brain. So what is the therapy for this? Acute therapy, you have a migraine headache, the first choice of treatment would be NSAIDs. NSAIDs are what? Ibuprofen, Aleve, Advil, any of those work. Even aspirin works, and caffeine. Caffeine actually works. It is a double-edged sword. In small quantities, caffeine actually works like a charm. But if you overuse, and you get rebound headaches and medication overuse headaches. And same thing with the other medications as well. Triptans are a class, you must have heard about it, sumatriptan and so many other in the class. They work as well, but they have to be used in caution with the people who have previous heart disease, or heart attack, or a stroke. You don't want, because what they call is they constrict the blood vessels, and you don't want them to have any constriction of the blood vessels and compromise the blood flow. So you have to be very careful about those, and also in uncontrolled hypertension and also hemiplegic migraine, because in hemiplegic migraine you don't know whether they're hemiplegic in the sense that's a complicated migraine, whether you have weakness on one side, you don't know whether it's actually stroke, so you've got to be really careful about that. But like I said, most of them are like abortive treatments. These are all the abortive treatments we have, including new ones, which are called as the GPANs, and also the CGRP ones. So there's Nurtec, there is Ubrelvy. I think Williams comes in for the ads on the TV, the tennis player Williams. Um, when you go to the preventive, so those are the abortive treatments, and you come to the preventive treatments. Propranolol works. These are all medication, but they work very well. Topamax or topiramate, then one of the tricyclics that psychiatrists use for depression also work. Lamotrigine does, and then if these are not, medical therapy sometimes doesn't work in some individuals, and you get Botox. So, but you have to get it every 3 months. Then there is trigger point injections where you give in some trigger points and then you give these injections. They help as well. The new class, like I said, the CGRP monoclonal antibodies. These are the 3 ones that I listed here: is Aimovig, Ajovy, and Emgality, and you get it, once a month. So it's just an injection that the patient is trained to, and then you can just give it on your thigh or your belly. That works. Vyepti is the same class, but it's actually an infusion. You get it, once a month as well. If these don't work, then we have more things like neurostimulation. Europe came up with a band called Cephali. It's still available. They use it. You wear it, a band, and it's nothing. It's just like a wearable band, and that helps as well. But it's not covered by insurance in the US, and it's been very expensive. Then there are other neurostimulation methods like transcranial magnetic stimulation, transcutaneous supraorbital nerve stimulation, vagal nerve stimulation, and so many other ones. And then the last one is sometimes you're all on these medications, you want behavioral therapy can help. It's an adjunct treatment though. Next slide. Then we come to exertional headaches. As the name indicates, exertion is physical activity. You get, people run or do excessive workout. Usually it's overzealous workout that causes that. So it's pulsatile. It can last from just 5 minutes to up to sometimes 2 days. And usually, like I said, after physical exertion. Most commonly seen in men than women. And like I said, it's more sustained physical activity or more aggressive workout that causes. Some of these headaches are also associated with sneezing, laughing, anything that kind of, doing that, or excessive crying. So there's an emotional component as well. Coital headaches, people usually come and they think it's actually bleed. So they are explosive in onset and you need to exclude a brain bleed. So those patients who come in with these headaches, you get the history and it's a coital headache, you have to get an MRI to make sure it's not bleed. You prevent these usually if you're working out, or if you can working out or doing any activity, you can pre-treat with indomethacin and that works. That completely avoids the headache. Next class is the tension type of headaches. As the name indicates, it's some kind of a stress. There is a vague symptom. There's a lot of physical and mental conditions, comorbid conditions associated with these most often. It's kind of ill-defined, kind of a vague heterogeneous syndrome associated with predominantly headache, but sometimes other symptoms as well. So this headache pain is not localized on one side or another. It doesn't quite localize to one area of the head as well. It's usually not aggravated with any activity, and it's not severe. It's like a dull headache, but it's a persistent headache. Nevertheless, it is discomfort to the patient. So you have episodic and you have chronic. The episodic headaches typically last from 30 minutes can be up to 7 days. The chronic ones are, chronic headaches are relatively almost continuous. They say, I wake up with a headache, I go to bed with a headache. They're continuous. So, like I said, several psychiatric conditions, even medical conditions, like someone who has lupus, or someone who has rheumatoid arthritis, or someone who has fibromyalgia, or chronic pain syndrome, they usually have this kind of a tension headache because I think their muscles are so stiff and they're so spasmed. That's what I think triggers the headache. So given the symptom overlap with these tension type of headaches, you have to exclude other conditions and treat the headache. So the exact mechanism is quite not known, but muscle spasms, and they're very sore in all the muscles that usually seen. So non-pharmacological intervention actually helps with this, including, people do not sleep very well because there's so much muscle spasms and discomfort. So sleep regulation or helping them with something to help them sleep at night, including melatonin, works. Regular meals, regular exercise, stress management, passive and active range of motion in the neck, muscles that improve your stretching will help. And then, of course, behavioral therapies play an important role in this particular type of headache, including biofeedback and cognitive behavioral therapy, or all these adjunct treatments. But you can always take aspirin and any of the NSAIDs, including, ibuprofen, Advil, Aleve, are effective. If still effective and you want to be on something like, if they have difficulty like amitriptyline or nortriptyline, they also help you sleep. So you can use that at night to help them sleep and also control the headache. Mirtazapine also is one of the soporific agent which helps you sleep. And then of course venlafaxine to treat chronic tension type of headaches. Next class is the cluster headaches. There are two major forms. One is actually the episodic one, and the other one is a chronic one. And you use the term attack because it's like very sudden in onset. It's a distinct attack of pain. It is severe, and a bout is usually defined as a cluster of them. So many of them occurring very frequently, like a cluster of headaches. So the episodic is characterized by these bouts of headaches lasting for up to 7 days, but can also be for 1 year. But they do have periods of relapse. They can last anywhere from less than 1 month, or sometimes even exceed a month. Whereas the chronic ones actually last longer period of times. They can actually last for throughout the year with only relapse of like less than a month or so. So like I said, the headache is very rapid in onset. Sometimes it just starts and builds up, peaks up in about 10 to 15 minutes, and can last up to 3 hours sometimes. It's always on one side, but sometimes you can have on both sides as well, or starts on one side and then transforms into the other side as well. Some of the symptoms you see is most of the time they describe as eye pain. It's either behind the eye, above the eye, or below the eye. So usually eye pain is a characteristic feature, and also in the temple region. And then you also have something tenderness in the neck along the carotid arteries. And typically the pain also follows this nerve. There's a nerve called the trigeminal nerve, and it has 3 branches. One goes here, the other one here, and the other one along the jaw. So you can have pain along the entire face, because this pretty much encompasses the entire face, right? So you do have that. Next slide. So there are some migrainous features associated with it, but you can have a little bit of nausea, not so much vomiting, but light sensitivity, sound sensitivity. And one aspect that is very peculiar to cluster headaches and no other headaches is the periodicity. It occurs around the same time, more or less the same time of the day. And this actually synchronizes with your circadian rhythm. So usually it's in the morning, or in the middle of the night, or in early morning, or late at night. So it follows the circadian rhythm. Then you do have nocturnal ones. They can wake you up from sleep. They follow, they actually can happen in the REM sleep or non-REM sleep as well. Again, like I said, it's excruciating pain. People describe as worse, but not like the worst headache of my life, but pretty severe, pretty debilitating. The characteristic feature of this is, in addition to having the periodicity, is you do have the eye pain, but you can also have some tearing from the eyes. You have nasal congestion. Sometimes you can have nasal leakage as well, as if you have cold. You have redness in the eyes, nasal stuffiness. So that's why, because it follows the distribution of the 3 divisions of that trigeminal nerve, so you have everything involved. It almost looks like it's a sinus pain. Next slide. So what actually induces or triggers is alcohol can, nitroglycerin. For patients who have angina, you treat them with nitroglycerin or have mild MI. That actually can trigger sometimes this headache, and histamine. You have allergies, and colds can also do that too. So what is the treatment for that? Usually a steroid treatment for about 6 days, 7 days. Sometimes you can have, if you have chronic ones, and you have to treat them for a prolonged period of time. But hyperbaric oxygen, this is oxygen you go into the chamber, which is at a high pressure. That helps. Triptans do as well, and dihydroergotamine is another medication that we use. Not commonly used these days because of the adverse effects, but we used to use it in the past. For prophylaxis, again, propranolol works for this one. Actually, most of the times propranolol is the medication of choice for prevention. Verapamil can be used, lithium can be used as well, and then valproate and Topamax as well. In severe cases which are refractory, then you may have to do actually occipital nerve block. So you do injections like every month or so for a few months, and then you go into remission, and then you don't have to do anything about it. Next slide. Now we come to the secondary headaches. So the primary headaches was what I talked about. There is no particular underlying etiology. There's no particular underlying cause. Sorry, I go into these medical terms, but so there's no underlying cause. You get the headaches for no apparent reason. And if you do any imaging study, there's nothing there. So it's not indicated. Most of the times we do it if it is severe and we want to rule out anything. Like if somebody comes with migraine headache with numbness and tingling or inability to move your hand or arm, we have to rule out the stroke, so we do the MRI. Secondary headaches is there's usually something underlying and it manifests as a headache. And one of the one of the important ones, I think, for secondary headache is an underlying brain tumor. Okay. So, but usually it is a common symptom, but there's always associated with it, if it's, there's an associated confusion with it. There is also associated seizure with it if it's a brain tumor. Its headache is a common symptom, but it's not the sole manifestation. So headaches associated with the brain tumor are a little different with straining, like when they're straining to go to the bathroom, to move their bowels, the headache is explosive at that time, or with exertion, or with coughing, it's really severe. It doesn't remit afterwards. Like the other headaches, like sort of cluster headaches or exertional headaches, they kind of improve. This tumor headache does not. There is no remitting with that. And they may even wake up from sleep with a severe headache. And usually it is one-sided, and it's often accompanied by confusion and seizures, as I mentioned. It's like this. So this picture, like you see, these are the brain tumors. So you see the bright spot. The black one is actually the swelling because this doesn't belong there. There's a lot of swelling. If you look at it, there's another small one there and there. So it actually doesn't belong there. It's a space-occupying lesion. So it's compressing against the brain tissue. The brain mass is being compressed. The headache is manifested that way. That will also source of irritation to the brain. So you manifest a seizure as well. And same thing here. Look at the amount of edema. Look at the amount of swelling here. And so also here, you don't see the lesion. It's a very small lesion, but probably you see the swelling around it. It's like this. So secondary headaches can also be from infection. Be that infection be actually like something like meningitis or something like an abscess. So again, this is a mass lesion, doesn't belong there. So it will exert some kind of a pressure on the brain mass. Sometimes it's severe enough, it exerts too much pressure that one half of the brain gets pushed to the other side as well. In that case, you have several other manifestations. But seizures usually manifest even with a brain abscess. So it's usually localized and becomes like encapsulated. It becomes like a wall capsule around it. You can see that on the MRI. Like I said, again, it's pushing, it's mass effect, so it causes the headache. Usually with this abscess or any infection, there's a fever along with it. With the tumor, you don't manifest it fever, but here there's actually a fever as well. And when you have a fever, you have to rule out an abscess. But usually, normally, immunocompetent people who do not have any problem with their immune system rarely have abscesses in the brain. So this is usually seen in immunocompromised patients, particularly HIV, but you don't have to have HIV. Somebody has rheumatoid arthritis and they're on high-dose steroids or methotrexate. There's an immunocompromised state there. So those people are also susceptible to that. But most often seen in HIV, and this particular infection, toxoplasmosis, is commonly seen in HIV patients. So this is a brain abscess. I was talking about how it gets encapsulated, nice rim around it. You don't see that much swelling, but in this you see the swelling around it. And so this is also behaves like a brain tumor, but there's fever associated with it. And this is an emergent one. So you've got to treat the underlying infection. Of course, you treat them with steroids to decrease that swelling so that they get relief of the headache. Next slide. So then we come to the meningitis. People have heard a lot of meningitis. So meningitis, basically, this is a Latin term. It means it's the coverings of the brain are called meninges. The inflammation and infection of the meninges is meningitis. So a severe headache, the present with severe headache, there's usually neck pain associated with it, and there's fever. And people are very withdrawn, they're curled out in a ball So there's lethargy with it. They're very sick looking. It's bacterial. Now you have bacterial, you have viral as well. Viral is usually called as an antiseptic. Bacterial is a very sick looking person with fevers. And the neck stiffness again is because of inflammation of the meninges. So they present with the neck stiffness. For this, even if a child if a newborn goes with a fever, we have to rule out it's meningitis because this is extremely treatable condition. So spinal tap is necessary. So we take some fluid out for diagnostic purpose so that we can tailor the medications accordingly. But most of the times we do that, we call that empiric treatment. We anyway treat them with strong antibiotics like vancomycin and cefepime so that the treatment process can stop. It's usually treated with steroids because there's so much inflammation. You'll relieve the headache, you'll relieve the pressure as well. For bacterial meningitis, can be from TB, and this is really TB meningitis is very rapid. Patients decline rapidly without intervention and can result in death as well. It's commonly seen in India and other developing countries. So aseptic or viral meningitis usually is treated with antiviral medications. Next slide. So here we see, so there are two pictures here. One is the bacteria. There are three layers. The meninges are called three layers. The most outermost is the dura layer, and let this be colored as a pachymeningitis. Pachy is again a Latin term meaning it's thick, like elephant is a pachyderm. So same thing. See how thick it is and everything. That's the dura that's involved. In the leptomeningitis, you have the two other layers. You have the arachnoid and the pyomatter. So that's what is involved. So the pyomatter, you see all that? That's all that. So this leptomeningitis is going into the inner layers. This is just the outer layer meningitis. Untreated, it goes inside as well. So it's very important to get to treatment right away. Next slide, please. So now we come to bleed. Now the bleeds are also two types. One is actually the bleeding outside the brain. It is in the vault or the cranium, vault of the brain. It's outside the brain, inside the vault, but outside that outer member called the dura. And then there's interbleed, intracranial bleed, which is actually in the brain tissue. Okay, so in the brain tissue or like involving the innermost membrane. So those two are much more deleterious than the one that's affecting outside the dura but inside the skeleton, inside the calvarium or also called the vault of the brain. So intracranial bleed commonly seen in elderly and alcoholics. We refer to that as subdural hematoma. So it's not in the brain tissue per se, it's outside. It's affecting the dura and between the skull and the dura. I'll show you the picture. It's better, I think. But usually seen in the elderly. And why in the elderly? Because your blood vessels become very fragile. You can fall. Sometimes in the elderly, you don't need to fall. You can just bump against a cabinet wall or something like that and have a subdural hematoma or subdural hemorrhage. In the alcoholic, same thing. The blood vasculature, the architecture is so fragile from the alcohol that they are, first of all, they're susceptible to falling, but even a small fall can lead to bleed in them. So they can present like, with a subacute, or really what happens, the headache is a manifesting symptoms. But if you ignore the headache, gradually you will see as the patient manifests with symptoms of confusion, sometimes even lethargy. So like even remembering where they're driving, even if they're driving in the same route every day, they get confused about using appliances and stuff like that. So regardless of that, it's still a mass lesion. It doesn't belong. Again, blood doesn't belong there. So it's exerting this mass effect and compressive effect and presents similar to the headaches with brain tumors. So usually you get history from them. Is there any head trauma? Is there any fall? And the CAT scan is actually very sensitive, but if CAT scan sometimes does not show, then you may have to go to an MRI. But for the most part, CAT scan is very sensitive. So if it's large and you cannot, and the patient is manifesting symptoms, then you have to drill those burr holes through the skull wall to evacuate that. This is where it says, so this is actually the dura membrane, how it's pushing the brain tissue. So this is between the skull wall and then that. So it's accumulating, so it's pushing against the brain tissue, and that's when you need to do the burr holes and evacuate that hemorrhage, the blood. So now we come to, these are the worst headaches. People will say the worst headache of my life. Most of them, that was 85 to 95% of the patients described as the worst headache of the life, and headache is the primary complaint here. Headache is usually followed by pain, which radiates to the head. Neck is involved as well, and still neck stiffness, similar to meningitis, because again, blood is the focus of irritation to your brain. So you do get that irritation, and the neck becomes very stiff. So as the blood flows into the spinal canal, it is spinal arachnoid, subarachnoid space. It actually irritates the meninges. You often see double vision. Sometimes you can have loss of consciousness, because depending on how big the bleed is or where the bleed is. It can occur due to the sudden rise in the intracranial pressure, because there's blood gushing, right? And it doesn't belong there. And then all of a sudden the blood pressure also drops. So 10 to 80% of the patients present with a warning headache prior to that, because if you have an aneurysm, say, and it ruptured, It's like a thunderclap headache. It's like an explosive headache. It's so sudden. But prior to that, you have a sentinel headache, which is a small headache. It's not as severe as that. That actually precedes. It's like a warning sign, and then you have the thunderclap headache. Next slide. What are the risk factors for the brain bleed? One is the aneurysm. So it ruptures and you have it. The other one is uncontrolled blood pressure. Then you have a condition called polycystic kidney disease. They are prone to having a lot of aneurysms. That's a genetic condition. They can't do anything but screening. Surveillance screening is very important. If you have any family history of brain aneurysms, you need to get it. The rest of the members have to. Cocaine. Cocaine also causes vasoconstriction. It causes a thinning of these blood vessels, and then you can have bleed from that. And it also changes the blood vessel architecture. Smoking is another risk factor for bleeds. Again, vasculitis, which is basically inflammation of the blood vessels. There are some conditions which are susceptible to, like lupus is, and sarcoidosis can cause vasculitis. So there are conditions where you have HIV as well. Then you have connective tissue disease, again, which are prone to vasculitis and causing rupture of the blood vessels. You have something that you're born with, the cavernous malformations. They are easily susceptible because they're more of an anomaly. The blood vessels are not as secure, so they have, and heart infections like endocarditis is susceptible to bleed as well. So CT is the test of choice, is the diagnostic test of choice. It is very, very sensitive. The sensitivity is very high in an acute phase. But if you leave it longer, sometimes the sensitivity decreases. And in that case, you have to do a spinal tap to make sure that there is no blood in the spinal fluid. Again, to detect an aneurysm, if it's unruptured or there's a small leakage from that, to detect is a cerebral angiogram. And most often we put them on antiepileptic medication, even if there's not a seizure, because like I said, blood is a focus of irritation to the brain tissue, and you do have to put them on seizure medications. What do? We have to do endovascular coiling or clipping of that aneurysm and secure it so that you don't have any bleeding in future. So like I said, this is actually intraparenchymal. We call that parenchyma. This is the blood tissue bleed. And usually it is pretty contained sometimes, but you do have, and it can mimic like a regular stroke. Say for, now this is in the right side of the brain, because radiographically you're looking at human being this way, this is the left half and the right half. So that's it. So they manifest left-sided symptoms. They can have numbness, tingling, weakness because of periodontitis or acute confusion too. But when you come to it, this is the subarachnoid bleed. So you see that these hyperintensities or lighter ones are blood. They don't belong here. These are cisterns. So blood has crept from the arachnoid space into that. And there is swelling because you normally see a brain should have these, cells like a walnut, but it looks very compact. There's so much swelling. And this is usually poor prognosis for actually the patient even making it. You can put them on, to relieve medication to relieve that swelling, but often what happens is they herniate because it's like a wart. Can't go anywhere else, right? Because it's like a wart to the skull. So it actually goes, that's called as a herniation, goes into the spinal canal and then results in death. Next one. So now we come to idiopathic intracranial hypertension. For whatever reasons, idiopathic is, nobody knows why, but the blood pressure in the body when you check may be normal, but the blood pressure is high in the brain. And that can manifest as headaches. It's otherwise known as pseudotumor cerebri. Pseudo is false in Latin, tumor. It behaves as if there is a tumor, but there's no tumor. When there's a tumor, like I said, it's pressure, it doesn't belong there. So it increases the compression, it increases the pressure. This behaves like that, except that there's no tumor, no lesion, no space occupying mass, but it behaves like that because the pressure is high. And headache is similar to, as if it's associated with a tumor, except that you don't manifest with seizure. The headache is not as intense. Usually seen in women who are overweight or obese. What do they have? They have double vision, but more importantly, they have loss of vision or at least visual deficits of the peripheral vision. The central vision is preserved. It's only the peripheral vision. And they also have some visual obscurations, they don't see very well. Because the swelling of the optic nerve, the pressure in the brain, because the optic nerve is actually contiguous with the brain. That's why when you look through this fundus eye exam, you can actually see the back of the optic nerve and you can find out if there's swelling or not. So usually the optic nerve, there's swelling there, and that often causes that. So you can also see these flashing lights, zigzag lines, scintillating scotomas, and and pain behind the eyes as well, and sometimes even ringing in your ears. So you can also get radiating pain if the pressure is very high. It can transmit down into that. In the neck, we have these nerve roots, right? So it can affect that and get neck pain as well. And neck pain, and sometimes even the arm radiating to the arms as well. Next slide. So the treatment, what we do, we treat with something, a mild diuretic, it's like a water pill, we call that as acetazolamide. But most of the times, if it's mild, it works. If it's severe enough, there's no other treatment. Here, in meningitis, in the brain bleeds, when you do the spinal tap, you're taking some fluid from the spine, you're doing it only for diagnostic. In this case, it's actually therapeutic. Patient gets immense relief. You do the lumbar punctures. Sometimes you may have to do a series of them to relieve the pain. But the most important thing is weight loss. So weight reduction can help immensely. You put them on medication as well. In emergent cases, if it's not really, and then they're at risk of losing their vision, then you have to do this optic nerve. The fenestration is just a punching. Fenestration is again Latin word, is just a hole. You do that to salvage the vision. Next slide, please. So now this is spontaneous intracranial hypotension. That was hyper, right? That means high blood pressure. This is low. Although they represent the opposite end of the spectrum, that one was actually intracranial hypotension, which is increased in the blood pressure. Well, it's not blood pressure, it's pressure in the brain. Here it is actually the other way, but both pretty much have similar clinical features. That's why I think it looks very astute neurologists to recognize what it is. So they do share many similar, features new with pseudotumor cerebri. So there is a marked variability in the location and the character of these headaches. So you have to identify, most often there is a leakage somewhere. There is spinal fluid leakage somewhere, be it not necessarily in the brain, but somewhere along the spine. So it's very important to recognize. This becomes a very challenging condition to detect the leak site. So we do a study for that, an imaging study, and then if you feel with dye, and then if you see there's a large pool, then you pool of contrast, obviously, we identify the leak, and you do what you call as an epidural blood patch to seal that site so that there is no leakage. Next slide. Then you come to the orthostatic headaches. This is usually, strangely enough, you get lumbar puncture or spinal tap for whatever condition you get it. Sometimes even for multiple sclerosis, because the diagnosis is a diagnostic test. You do the spinal fluid for analysis of the CSF, or you could get it for meningitis. Patients present manifest with a headache, but this headache is peculiar in the sense when you're laying down, you barely have or very mild discomfort. The headache is severely exacerbated when you stand up or sit even. So it's highly positional. That's because your blood pressure is dropping, and then you get stiff neck with this, you get nausea, you get sometimes blurred vision, and also ringing, but it's pulsatile ringing. It goes with like how your pulses, same thing, goes periodically. You can also get some numbness and tingling in the arms too. So for this, what we do again is, usually if you do a spinal tap, you tell the patients to drink a lot of fluids, lay on their back for about 4 or 5 hours, or even a caffeinated drink. Caffeine actually helps seal that epidural membrane so that you don't go into these headaches. But if they do get these headaches, then you have to do the blood patch. Sometimes there are conditions where you actually there's excess amount of fluid and you have to drain, and you put these what we call as a BP shunt, which we referred to in one of these previous ones on dementia when we did the normal pressure hydrocephalus. I was talking to you about it. It actually drains the fluid to the cavity outside the gut and everything else. In that case, sometimes over shunting can cause these headaches. So all you have to do is you have the device and you adjust make the adjustments, calibrate it so that you're not draining too much fluid to develop this headache. But caffeine, like I said, and fluids help, and if not, then you have to do the blood patch. Again, you take your own blood, you put it as a patch in that epidural membrane so it seals, and then you get a headache. Next slide. This is a very important entity, cerebral venous sinus thrombosis. So we heard of strokes having like arterial in the arteries if there's a blood clot, or if it's a plaque, you have stroke, right? This is the venous system. Now, venous system in the brain, we always call it as sinuses. So venous sinuses, and you can have a clot in the venous sinuses, in the venous system of the brain, and that can manifest as thrombosis, means actually blood clot. So cerebral, brain, venous sinus thrombosis. So you often present with these headaches, which are very, very severe. Most of the times you see in pregnancy or postpartum, right after delivery, you can see that. So this is again, if a pregnant woman comes and complains of a headache, this is the first entity that you need to rule out. So again, what they manifest is headache, swelling of the optic nerve, sometimes even focal weakness, because if it is blood clot, it's not draining, like veins drain your blood, right? I mean, veins, so if the blood clot there, you can actually have a stroke as well, secondary to that. So it's not unusual to manifest with, focal weakness on one side, numbness and tingling as well. So you have to have that suspicion. It should be very high, particularly in a pregnant patient. So because of the, complications, clinical complications, the diagnosis may sometimes be challenging. You have to resort to imaging. So, and the choice of the diagnostic test that we do is CT venogram. So you have to give them the and do the CT venogram. We're looking all at the venous sinuses of the brain. Or you have to do the MR venogram, which is magnetic resonance venogram, similar to MRI, but here you're looking at the venous system. And what do you do treatment? Immediately you put them on heparin or the Lovenox, but eventually you have to do them for a few months on blood thinners. Then you do a surveillance follow up with another MRV, make sure that there's no thrombus or the blood clot in that. So again, like I said, seen in pregnancy and also postpartum as well. Next slide. So this is an important entity, again seen in patients over 60. Giant cell arteritis, temporal arteritis is also known as, and what do they manifest with? A severe headache, and usually it's always in the temporal region, severe headache. But there's also, with the headache, how do you differentiate between this and the other one? It's a severe headache, but you also have other symptoms. Usually you have fever. In addition to fever, you have scalp tenderness. And the tenderness is so severe that it's pain elicited with mere palpation. With just touching the scalp, you elicit pain. Then you have jaw claudication, severe jaw pain, hoarseness of the voice, muscle aches, painful even swallowing, and then muscle stiffness, in addition to the temporal pain. If you're untreated, then you're at risk of losing the vision. People don't get in a timely fashion, they go blind. So salvage the vision. Steroids are the line of treatment. The steroids are fairly high dose and for a prolonged period of time, and then you do the temporal biopsy. But the problem is it's a catch-22 situation. You want to treat them with the steroids. Sometimes the biopsy can be false negative. That doesn't mean it's not there, so you may have to repeat later a second biopsy to make sure that it is temporal arteritis. Okay, the one other entity is post-concussive headaches. Again, headache manifested because there's a concussion. There is a trauma to the brain. It could be, like I said, it could be playing sports and having a concussion. You don't have to have loss of consciousness, but most of the times you do have loss of consciousness, or it could be a motor vehicle accident, or it could be just bumping against a headboard or a cabinet causing something. So again, the headache is associated with difficulty focusing, blurred vision, dizziness, even some memory lapses, like short-term memory lapses as well. Usually the symptoms get better with time, about 8-10 weeks. I think usually things improve depending on the impact of the injury. In football players, of course, the impact is, when the 300-pound person comes and does, the impact is much more. And if they have several of them, then they go into the realm of chronic traumatic encephalopathy. So trauma usually is the one, and if people have migraine headaches in the past, the trauma can actually make the headaches worse, both in terms of the intensity and the frequency. If without any history of migraine headaches, even then they become susceptible to migraines. Next slide. Then we have the trigeminal neuralgia. We alluded to it earlier. Like I said, this is the nerve with 3 divisions, and it is a type of a headache which is very painful, exclusively on one side. And it actually follows the distribution of the 3 divisions of this nerve, involving the upper portion of this, the middle portion here, and then the lower part of the face. So these headaches are like excruciating jabs, or like electric shock kind of sensation, but they're only very short lasting. There are multiple of them. So intermittent, transient, lancinating. That's what it is. You take a lance, like people who test diabetes, they lance, right? That's what it is. It's sharp. And they occur very frequently. They do experience a refractory period that can last for minutes to hours, but it's just constant. The pain is so severe, and it can even be stimulated, triggered by even touching or light wind blowing against their face, or even chewing sometimes. And the trigger zone, there are trigger zones in the distribution of the three divisions of this nerve. So patients usually avoid chewing on that side, they resort to chewing on the other side. They avoid washing with cold water their face, and shaving is a problem for them. So a lot of restrictions in their normal activities. And that's an important one is these trigger zones are there and they produce pain, and that's one way to differentiate this trigeminal neuralgia. Next slide. Pain is often characterized as, like I said, electric shock, lancinating pain, and the pain is so severe that they just grimace, and that's why the Latin word tic doloro. Tic is they're doing that, they're inadvertently doing that, but it's actually incited by so much pain. Tic and doloro is the Latin word pain. Typically, women are affected twice as often as men. I think women, migraines, most of them are like women more than men. Usually there's no sensory loss associated with it, but very rarely you can see some minor sensory loss, but it's pain, exclusively pain, no sensation loss. So often they have, pain in this distribution. They think it's a tooth pain or something related with the gums. They often go to dentists, sometimes go to maxillofacial surgeon, and then they come to the neurologist. And obviously, there's nothing wrong with their teeth. There is, no problem at all with that. But sometimes after a procedure, dental procedure as well, if the trigeminal nerve is irritated too, they do manifest. So then, like the trigeminal neuralgia sometimes can be in combination with the cluster. Then we call it the cluster tic syndrome. Next. So what do? We just want to make sure with an MRI to exclude multiple sclerosis, because multiple sclerosis symptoms can manifest this way: numbness, tingling, sharp pain. So you want to make sure it's not multiple sclerosis, but you also want to make sure that it's not a tumor pushing against the fifth nerve, the trigeminal nerve inside the brain. So you have to do for that purpose just to exclude. Or even to exclude it, there's a small blood vessel that is actually impinging on that fifth nerve or the trigeminal nerve. And the treatment is usually with these medications. They work like a charm, either carbamazepine or it's related medication called as oxcarbazepine or trilactol. Now, if they use these medications and they still have the pain, then you actually have to use baclofen or nortriptyline is used as well. If nothing else works, then you resort to more, radio frequency, do the gamma knife radiation to actually relieve the nerve root. Sometimes you inject glycerol, rhizotomy. It's called rhizotomy. Is again, rhizo is nerve root for Latin word, and rhizotomy you do that, then gamma knife surgery as well. Sometimes you don't want to do all that because there's some associated swelling, then you can do actually the intervention with a microvascular decompression. So what you do is you use a Teflon gauze and put it in between the nerve and the blood vessel to relieve the pressure. Next slide. And that's it. Okay, we're done. I thought I had more slides. But I want to talk to you about one which I didn't have. The last one, but not the least, it's called as a Chiari-1 malformation. The one the neurologist who discovered was Arnold Chiari. So they often present with the headaches. The headaches are more at the back. They're constant headaches. Sometimes they have neck pain, also pain, tingling, numbness, dizziness as well. That's because in the brain where it sits, there's a cerebellum, which is called the little brain again in Latin. It doesn't belong, it belongs above the spinal cord, right? Spinal canal. Sometimes there are tonsils, not these tonsils, but the tonsils of the brain. They kind of descend into the spinal canal. They don't belong there again. They're exerting pressure. That's why the headache is here. And usually if medications don't help, they have to go for surgery, which is basically decompressive surgery. So they go in and try to relieve the pressure by pushing up these cerebellar tonsils. That's called as a Chiari-1 malformation. There is an exclusive clinic in New York dealing with this Chiari-1 malformation, a surgeon who does exclusively those. And I think I would go there for this place too. Thank you so much for your attention, and I'll be more than happy to take any questions.
Do we have any online question? Okay. So, any questions here?
Any questions from here?
I have a question.
Sure.
So I understand it's brain bleeding and everything. Is any of it, at what stage does it turn fatal?
So if it depends on, right? If subdural hematoma is not fatal, But like I said, the confusion and it does push against the brain, but it is not. But it can then manifest. But it needs to be addressed because then, like I said, if it's like a huge one, like I said, extreme case, and small ones you don't need it. You just treat them for the headaches, and then you keep monitoring. That's okay. The subarachnoid or the intraparenchymal hemorrhage, which I showed, that can. If it's a small bleed, even in the brain tissue and it's contained, it's okay. But subarachnoid, it creeps everywhere, causes the whole brain swelling. At that point, if you treat them with mannitol, if you treat them with, high density saline, we call hypertonic saline, you can really establish because it's global. And then that's the point when you talk to the family to make them as either comfort care or like withdrawal care.
And the other thing is, I understand it affects our day life. Any headache might be
Yeah,
too much.
especially migraines because it can be pretty debilitating. Yeah.
But does it also affect cognition, or is it depending on the place where the bleed is located?
Oh yeah, I mean,
Except-
cognition per se, because the bleed doesn't happen in hippocampus, which is the seat of memory, right? So usually it's not cognition, but confusion, subdural hematoma can present like that cognition. Like I said, they can't use normal gadgets because it's a subdural hematoma. Normally they drive through the same route every day, and then they just can't drive anymore. So it does cognition, it does it. Subarachnoid, usually they're like loss of consciousness. If it's severe, they're not with it. They're lethargic or even obtunded sometimes. But subdural hematoma can affect the cognition. Not necessarily intracranial, intraparenchymal, but in the tissue of the brain.
So, question, talking about different headaches, you mentioned various things. So, take home point seems to be that if you're controlling your blood pressure, if you are
Abstaining from smoking,
smoking,
Mhm.
alcohol, then
drugs,
drugs, stress. So, if
diabetes and high cholesterol as well.
right. So essentially, if healthy lifestyle, if you are following very healthy lifestyle, looks like a lot of these headaches are generally health.
Yeah, migraine not necessarily. I think I refer to that. There are food triggers, so maintaining a journal, food triggers, avoiding
Yeah.
like chocolate, nuts, cheese are the triggers. So you maintain a journal and avoid those triggers, at least or reduce that, then you can take care of the migraine. I don't think stress itself per se, but tension headache, stress plays an important role there. Again, with bleed, if you control all that, you have some conditions, you have a propensity to bleed, right? Like polycystic kidney disease or AVMs, if you have, arterial valve malformations, these are anomalies that you're born with and you can't. Tumors, you can't. So some of the headaches, particularly the tension type of headaches, are more amenable to, stress reduction and all that. Migraines too, I think to some extent, but migraines also, there are food triggers that you need to monitor and try to maintain a journal and, at least if you can't avoid eating chocolate, but at least reduce, so. Yeah.
Okay, looks like those are the questions that we have here. You can thank everyone. And
Thank you so much for this opportunity, and in 2 weeks' time, we're going to talk on Parkinson's disease. Again, thank you for your attention, and have a wonderful day.